Welcome to this SaferAfrica e-learning module. My name is Babette de Wilde and I'm working for VIAS Institute in Brussels. I will be your guide through this third session of the post-crash care module. So, as I said, we're now in the third session of the post-crash care module. As you might know, we've already given you a global vision on post-crash care and the different stages of medical care. Today we're going to take a closer look at the mental health care that's needed after an accident. As mentioned in the previous module, we will start today by exploring the rehabilitation of the victims, followed by the specific needs within mental health care. Let's start with the rehabilitation for injuries. Rehabilitation involves professionals from a wide range of medical and paramedical disciplines. They work together to help to achieve treatment goals. It are not just the physical wounds that have to be healed. It is also about the person as a whole, with both physical and psychological aspects. It's about helping that person to function as good again as before the accident. In some cases, this isn't even possible. Nevertheless, there still are a lot of options to help out. Starting rehabilitation as soon as possible and continuing for as long as needed are essential to limit the physical and psychological impact of injuries and to maximize the impact of emergency and surgical care. With this goal in mind, the victim must have easy access to assistive devices such as ortheses, protheses, wheelchairs, or other long-term treatments when necessary. Long after a crash, victims and their families can suffer from persistent physical and psychological conditions that, when not appropriately treated, restrict their ability to function normally in their work and their personal lives. When the main provider of a family is injured and unemployed, there must be a solution for the whole family, not just for the injured person. Adjusting to long-term physical impairment and associated disability or disfigurement can also put individuals at increased risk of developing psychological disability. Where no services are available, family members may provide basic rehabilitation care. Wounds from these accidents can vary from minor scrapes and bruises to much more serious injuries. Generally, accidental injuries affect each body part differently. The rehabilitation process after injuries differs depending on the body part and the severity. Some of the injuries won't need any additional attention, whereas others will. The necessary follow-up to prevent further physical injury can be done after the patient is released from the hospital. Victims can, for instance, visit a physiotherapist on a regular basis, so that suffering from back or neck pain, having strains and sprains isn't necessary. Physiotherapy specially targets pain, and this is the cornerstone of what this type of therapy aims to accomplish. It's a specialist treatment where techniques such as massage, manipulation, and exercises are used to improve range of motion, strengthen the surrounding muscles, and return the normal function of the injured body part. A physiotherapist can also develop an exercise program to help strengthen the affected body part and reduce the risk of the injury recurring. Injured people can also perform these exercises at home or during sports. Some people are less fortunate and experience chronic physical limitations. The rehabilitation process will be different for them. The normal functionality of the body will not come back, so rehabilitation revolves around learning to move with the limitation and to integrate it into daily life. With regard to the mobility of people with a disability, technology exists that can accommodate this. For example, a vehicle can be fully adapted according to the needs and the ability of the driver or passenger. Next to that, prosthetics are no longer an idea of the future, but are readily available. In Kenya, for instance, the organization Kipwezi helps people through the process. In Kenya, healthcare services remain very limited and are usually concentrated in urban areas. Government-funded surgical assistance is rarely available and private healthcare is far beyond the means of rural poor. So Advantage Africa supports Kipwezi Disabled Persons Organization to fill in these gaps financially. This project enables people with disabilities, including young children, to be properly assessed by qualified medical professionals and, when appropriate, provide access to life-changing corrective surgery or prosthetic limbs. Many potential beneficiaries of this project have been medically neglected as children and lack knowledge about their own conditions. The first step is, therefore, to help them and their families understand their impairment and situation and inform them of the appropriate services that are available to them. Proper assessments are then made and consultations with medical facilities or prosthetic workshops are organized. Besides personal vehicles, public transportation can also be adapted. Here's a short video about a bus driver who decided to help people with
There are some people who don't like helping them. They don't like carrying them because they are wasting their time. They take time before they can board a matatu on her lighting. Some even need to be lifted to be taken inside the matatu. But there are others who don't like even assisting them or can allow them to take the place. It is very hard for them to walk. Even crossing this highway, which is very busy, it is very hard for them to cross. If the owner gives you the vehicle, there is a target which tells you, I want this amount of money. So you are using your time when you should be making another trip. But you say it's only God who knows who it is better. It depends on the way you are brought up. I think I have been brought up the way of helping people. I think my mother taught me a good thing was he brought me up. So I have been living that heart of helping who are in need.
It's normal to feel some difficult emotions after a car crash, even for a month or more afterwards. Here's what to expect. After a car accident, you're often in shock. When that fades, you can feel any number of different emotions, all of which are totally normal. A large proportion of crash survivors experience acute and long-term psychological conditions, with the most common conditions being post-traumatic stress disorder, a major depressive disorder, and anxiety disorders. Anxiety is a natural reaction to a stressful incident such as a car accident. Most people will eventually have to get back in their cars after the accident. It is very normal to feel anxious about driving again, and they might also be driving more cautiously than before. For example, there are people who have to drive home in another car immediately after an accident. This is not impossible and can even be helpful in conquering your anxiety sooner. but you shouldn't expect yourself to just get over it straight away, and you may find that anxious feelings arise after you have already returned to the road. How to cure, or better, how to care for the victims will be addressed in the following theme, mental health care. For this session, we divided the theme mental health care in two parts related to the two big target groups. Let's start with the victims. After a traffic incident, victims may be in shock and show various reactions in attempt to recover. To a certain extent, these reactions are normal responses to an extraordinary situation. One person may perceive an event as deeply traumatic, while another does not. The bystanders need to know the priorities for helping someone after a traumatic event. Safety comes first, so they have to check for potential dangers before they approach the victim. The medical team that has to respond to a crash should be trained to identify the individuals who are at greatest risk for an acute psychological stress and offer them emotional support up to and throughout the treatment at a facility. It's important to offer dedicated training for hospital workers aimed at providing psychological support. For example, Stop Accidentes, this non-governmental Spanish organization, has designed an intervention package called Road Violence Victims Care to provide psychological support for survivors. These actions include creation of a supporter network of social workers and psychologists, dedicated training for hospital workers aimed at providing psychological support, an established support protocol that includes designation of a quiet physical environment in hospitals to receive families, and a written guide for crash victims. Not only professionals are helpful. Beyond the immediate aftermath, the extended post-crash response should include concealing and organized support groups to help affected persons navigate a path towards recovery and prevent psychological disability. Bereavement groups and self-aid groups are useful places to express and share one's emotions with people having similar experiences. Members of a support group usually share their personal experience and offer each other emotional comfort and moral support. They may also offer practical advice and tips as well. Not sharing the traumatic events prolongs the symptoms and creates isolation. Car accidents do not always have a good outcome. When a car accident was fatal, the psychological aid is centered on the relatives. This will mainly consist of psychological support after reporting the death. It is very important to have a good approach to deal with situations of this kind. Relatives usually go through 5 phases of grief, but how strongly someone reacts in a certain phase is very personal. Before talking about a certain approach to deal with situations of this kind, I have a question for you. How would you deliver bad news? Or how would you want them to deliver it to you? The Foundation MAPFRE is a Spanish non-profit organization, the main purpose of which is to promote the well-being of society and citizens. They have, among other things, made a guide on how to approach the relatives of a victim of a traffic accident. The guide consists of a number of phases that show you how to deliver bad news. First of all, Prepare the conversation. Assess the scale of the crash. Compile the information, verify it, and ensure that it's reliable. Setting. Have an appropriate setting. Find a private setting where the persons feel comfortable. Gather the relatives. Gather close friends and relatives. On the one hand, for those who have to bring bad news, this is more efficient. And on the other hand, the relatives can find solace together. Communicate. Communicate the bad news. Communicate the fact at a pace that the persons can follow clearly and concisely. Inform that something serious has happened. Explain it in general without excessive details. Take a lot of care over the communication of emotions and the therapeutic use of a hug. And get to the point. Await reaction. After you told them, await their reaction. Offer support if possible. Attend needs. Attend to needs and requirements. Facilitate arrangements and practical aspects. Do not just leave after you give them the bad news. Assist the people until they have processed the news emotionally. Accompany. The guidance doesn't stop after delivering bad news. The relatives must be assisted during their grieving process. This can be done with specific service or by specifically trained staff. Throughout this process, there are many normal reactions to getting such emotional news. Nevertheless, a number of reactions can generally be described as alarming. Alarming in the sense that the person who receives the news is too overwhelmed. Normal reactions to grief. Emotional signs or symptoms. Sadness, anxiety due to the absence of the deceased. Crying, feelings of emptiness, guilt, shame. Second, there are cognitive and behavioral signs or symptoms. Difficulty concentrating, disinterest in daily life, temporary imitation of the deceased person's habits, re-memorizing the deceased person as if they were still there. The third are the physical signs or symptoms. Sleeping problems, disturbed appetite, weight loss, sexual dysfunction, and so on. The last are the social and professional impact. Isolation, professional under or over-investment. So now traumatic grief. We talked about traumatic grief when the pain of the loss of a loved one is exaggerated by the traumatic stress caused by the incident. The loss of a loved one is traumatic, especially if it occurs without a warning, if it's untimely, if it involves violence, if there is damage to the loved one's body, if it was caused by a predator with the intent to harm, if the survivor regards the death as preventable, if the survivor believes that the loved one suffered, or if the survivor regards the death or manner of death as unfair. The bereaved person is doubly affected by the loss of the loved one, by the unacceptance and the traumatic aspects of the circumstances. Symptoms of grief and post-traumatic responses overlap. Persons in grief need attention. For example, Starting in 2007, in Rwanda, the organization Handicap International has initiated a project mental health community aimed at promoting the mental health by strengthening community prevention schemes and curative care for children and adolescents in a state of physical suffering in Rwanda. This project was rooted in a participatory approach that involved civil as well as public actors, co-acting with Rwandan partner organizations. From May 2011 until March 2014, a new project cycle has started with funding from the Directorate of Development and Cooperation Switzerland. And through this regional psychosocial program and aims at strengthening a health approach community-based mental health populations in vulnerable situations, psychological and social. Another theoretical model that predicts the response to loss is the Kubler-Ross curve. But there is not a typical response to loss, since the loss is not a typical event. The Kubler-Ross model defines 5 stages, being denial, anger, bargaining, depression, and acceptance. These stages are a part of the framework that describes how we deal with loss. The vast majority of individuals showed signs of depression, but they eventually came to accept the situation. Denial and isolation. The first reaction is denial. In this stage, individuals believe the diagnosis is somehow mistaken and cling to a false preferable reality. Frustration or anger. When the individual recognizes that denial cannot continue, they become frustrated, especially at proximate individuals. Depression. This is typically the lowest point of the curve. I'm so sad. Why bother with anything? I'm going to die soon, so what's the point? I miss my loved one. Why go on? During this fourth stage, the individual despairs at the recognition of their mortality. In this state, the individual may become silent, refuse visitors, and spend much of the time mournful and sullen. The way to acceptance. People dying may precede the survivors in this state, which typically comes with a calm, retrospective view for the individual and a stable condition of emotions. So we have reached the end of this session. It is important to think about a few keywords that have been given a meaning through this session. Reflect for yourself how these concepts come into play on the road according to you and which words are missing according to you. Rehabilitation is both psychological as physical. So, to care as well as to cure. These two types of aid are very different and therefore needs a different approach. Thank you for your attention. You can download a PDF of this presentation from the website. You can also download a PDF with references and further readings on this subject. Next session on post-crash care is side components of post-crash response.